All right. Good afternoon and welcome. Today is Tuesday, March 26th, 2024, and it is 12:05 p.m. Arizona time. Welcome to the fourth briefing of the Arizona Advisory Committee to the U.S. Commission on Civil Rights. And I'd like to remind everyone that this meeting is public and being recorded. My name is Christina Sandifer, and I'm a member of the Arizona Advisory Committee, and I will be chairing today's meeting by the request of our chair, Leslie Ross. I will now go ahead and take roll. So committee members, if you are joining by phone, please press *6 to unmute yourself and *6 to place yourself back on mute. Angela Banks, Rebecca Browder, Tessa Dysart, Patty Ferguson Boney, David Kim,
Present.
Teresa Rosas, Jonathan Rose,
Present.
Leslie Ross, Beverly Traver, Heather Whiteman Runsim, Henry Whitmer, and Eric Yordi. All right. And
Tessa Dysart is present. Sorry, I'm here.
Sorry, Tessa. I see you now. Thank you. All right, great. Well, we have a quorum present, so we will go ahead and proceed with the meeting. And also present are commission staff Anna Victoria Fortes, our new designated federal officer, and also Angelica Trevino, our support specialist. The U.S. Commission on Civil Rights is an independent, bipartisan agency of the federal government, and it's charged with studying discrimination or denial of equal protection of the laws because of race, color, religion, sex, age, disability, or national origin, or in the administration of justice. An advisory committee to the commission has been established in each of the 50 states and in the District of Columbia, as well as the 5 territories and commonwealths. They're made up of responsible persons who serve without compensation to advise the commission on relevant information concerning their respective states. The Arizona Advisory Committee voted to investigate the topic of racial and ethnic disparities in pediatric healthcare in Arizona. Today is the fourth of several web briefings that the committee will hold throughout the next few months, and the focus of today's meeting is on American Indian children. If you would like to receive notification of future meetings, please contact our support specialist at atrevino@usccr.gov.
So I have to call them, but I have a meeting at noon. I know.
Can I just ask everybody else to mute themselves, please?
Yeah.
All right. Thank you. If you'd like to receive notification of future meetings, please contact our support specialist at atrevino@usccr.gov. That's atrevino@usccr.gov.
Oh, okay.
Today's meeting is focused on American Indian children, and we'll be hearing from representatives of the Arizona Advisory Council on Indian Healthcare, Director John Molina, and Business Operations Administrator Alison Lovell. And we'll also be hearing from Gerilene Haskon, Tribal Liaison at the Policy and Intergovernmental Affairs Department at the Arizona Department of Health Services. Thank you all so much for joining us. In a moment, I'll invite them to present for 15 minutes each. And then after, advisory committee members will have an opportunity to ask questions. Now, this Q&A is reserved for committee members only. After the committee Q&A, we'll have a public comment period where members of the public will be given an opportunity to share their perspective and opinions on the topic. And if you're not able to share your full remarks today, please email your remarks to atrevino@usccr.gov for inclusion in the committee's proceedings. And then after we have public comment, the committee will then move into conducting committee business related to planning future briefings. If you're a panelist or a member of the public, you can choose to leave, or you can choose to stay on the call if you wish, as all of the advisory committee meetings are open to the public. Before we move into the presentation, I'll go over some key ground rules for this briefing. Again, this meeting is open to the general public, and I want to remind everyone again that this meeting is being recorded and it will be transcribed for the public record. I ask that you please state your name when speaking to assist with our transcription. All attendees should mute themselves when not speaking so that we can capture high-quality audio for the recording, and commission staff will also monitor sound output and might mute speakers with background noise. To view closed captions for today's briefing, please click the CC icon in the lower left-hand corner of your screen. Though some of the statements made today may vary from personal perspectives, we want to ensure that all invited guests feel welcomed and do not defame or degrade any person or any organization. As the chair of today's meeting, I reserve the privilege to cut short any statements that defame, degrade, or don't pertain to the issue at hand. Any persons or organizations that feel defamed or degraded by statements made in these proceedings may respond and submit written statements for inclusion in the proceedings. I urge all persons making presentations to please be judicious in their statements and remain on topic. The Arizona Advisory Committee appreciates the willingness of all participants to share their views and experiences with this committee. Now, as we move into today's presentations, I would like to introduce Dr. John Molina, Director of the Arizona Advisory Council on Indian Healthcare. And Dr. Molina, when you are ready, you may begin.
Dr. Molina, you can
Oh,
begin your
yeah, let me.
presentation.
Okay. Can you hear me?
We
Yes.
can, yes. Thank you.
Okay. Well, I apologize for the slight interruption. The thing with technology is you hit the wrong key, then you got to start all over again. Anyway, thank you for this invite. I really appreciate the panelists who are with me and also the advisory council members. For the record, my name is John Molina. I actually retired OBGYN and have almost 30 years experience working within the Indian Health Service System. Both with federally managed hospitals and clinics, tribally managed hospitals and clinics, and also urban programs, and both as an administrator and as a clinician. Although this is related to pediatric care and adolescents, as an OB-GYN, I had the opportunity to deliver hundreds of babies through the Indian Health Service, and also had really an opportunity to work sort of as a generalist, if you will, in my community of Guadalupe, Arizona, where a lot of my patients were the pediatric population and also the adolescents. And so my experience really has been working in rural communities and also within the urban clinics. But I think in general, we find that, at least what I've seen, is that we seem to have more issues related to pediatric care and the pediatric populations in the rural areas, or let me just say within the reservation-based area, where we see more concerns related to mental health concerns, suicide, and also substance abuse disorders. And it's unfortunate that although we relate this to a lot with the adolescent populations, in my experience, I found that a lot of these issues really began when in the much younger ages. I can recall an incident where I was taking care of a young adolescent at the age of 17, and she reported that she was using heroin. And when I asked her, how did this happen? And she said that her brother introduced her to the drug at the age of 12, but by the age of 9, she was already seeing her brothers using. So what impacts me is that not to focus on the patient themselves, but really the community and the family. Because what I've seen in my experience is that a lot of this drug abuse and alcohol abuse that is really tearing our kids apart in communities begins in very much early stages. One of the research that was done among, in trying to understand behaviors of people as they get older was the adverse childhood events. And some of you might know about this, the adverse childhood events, where there's certain events that take place during childhood, like being exposed to family violence, to members of psychiatric disorders in the family, and so on. So sort of some of the social determinants that when you score high on this scale, you're more at risk to get involved in behaviors related to substance abuse and alcohol abuse and violence. And the reason I kind of focus on this, even as an OBGYN, when I saw it, is that it really concerned me, that we really have to step back and dig a little bit deeper, kind of go upstream, if you will, to see where this is all happening. And I think that if the advisory committee is looking at ways to begin to address these issues of suicide, our young people who are taking their lives even before they're teenagers, where does this start? And I think I have to say that this really begins, right there with the family, with the community, understanding the dynamics of the community and, how it affects children as they're growing up. We have a 4-year-old granddaughter that is just amazing. But what's amazing about these young children is how quickly they pick up on modeling behavior. This is something that I've seen with children. They model what they see. They speak what they see. They do what they see. Their young minds are developing this neural pathways and a way of analyzing the world and seeing the world that I think we're missing the boat if we're just not looking a bit further deep to look at where it's actually beginning in the community, in the family. In my work in my community of Guadalupe, I saw substance use disorders and alcohol abuse that kind of runs in the family. It's not inherited; it's learned. It's learned behavior that is then just goes from generation to generation to generation. So how do you break that cycle? And I suppose that this is $1 million question to say, how do you break that cycle? And I anticipate that it kind of evolves around a lot of looking at learning models, behavior models, trauma-informed care, but more than anything, to begin to look at these hotspots of where it's happening, like especially suicide. I mean, suicide is related to substance use disorder and alcohol use disorder. And it just tears my heart to see our young people taking their lives. The thing that has destroyed the native culture is the loss of our generation. We're losing our culture because we're losing our kids. And I think from a cultural perspective, from a social perspective, we can't allow this to happen, because this is our indigenous people, or at least what I see as the first ones being here before colonization, is sort of getting wiped out because of this disorders that begins early on. And I'll just kind of close up with another thought kind of related to this, is the fact that the other thing that our young kids are losing, they're losing their identity as indigenous people. And that for me is the strongest factor that will prevent any of this risk behavior happening, because, this Western civilization and being acclimated to the Western world really tears a lot of our kids apart, because they're trying to live in two different worlds. When they go into the Western world, the environment where we see racism and prejudice and implicit bias and all these factors, they're questioning their own selves of, where do I actually belong? There's no sense of belonging, because what was once theirs is now lost. We live in a Western world dominated by a lot of other types of influences that impacts the way the child is learning. Because the strongest factor that I believe in from my own experience that kids have to be able to resist all the other things that impact them in a negative way is their sense of identity. And the sense of identity is not taught, connected to the Western way of life, but it's connected to them as indigenous kids. And this is where I think a lot of the healing can begin, is to begin to identify themselves as indigenous kids and give them the resilience. I'll just close with the other thing that I think that is important to look at is the high levels of obesity and obesity-related cardiovascular disorders. Adult 2 diabetes used to be found in adults. Now it's being found in preteens. And it's the thing that has to be addressed also in sort of a systemic way. A lot of tribes are moving towards being able to begin to grow the traditional foods again. Not only traditional foods that are healthy for the environment, but traditional foods that have a significant sacred type of connection to the world they live. So food is part of the nourishment, but part of healing. And this is something that I've seen happen in some of our communities here in Arizona, where tribally managed communities, tribally managed healthcare system are beginning to take, that self-determination to go back to the traditional way of life and away from the Western way of life that will certainly impact in the long run, I think, in reducing the levels of obesity and cardiovascular diseases that is tied into obesity. So that sort of is my my take on it, is at least in the work that I've done as a clinician, as administrator. And I think with that, I'll close if it's okay, or if there's any other things that questions folks might have.
Thank you so much, Dr. Molina. Really appreciate it. And we will, when all the presentations are complete, we will open it up for questions. So if you wouldn't mind sticking around, I'm sure our members will have some questions for you. So thank you. Next, we have Alison Lovell. Oh,
Madam Chair,
I guess, yes, David.
we could actually do the questioning for Dr. Molina before we start the next presentation. I think it's entirely up to you. We could have him wait until it's done, but
Dr.
I
Molina,
think-
are you able to wait, or do you need?
Sure. I can wait. I'm good.
Okay, I think if it's okay with you, David, we'll go through all the presentations and then have folks ask questions in case people want to ask questions of multiple panelists at once. And let them
of course.
respond.
Yeah, thank you, Madam Chair.
No, thank you so much. Good, David. All right. Well, next, let's move on to Alison Lovell, Business Operations Administrator for the Arizona Advisory Council on Indian Healthcare. So, Ms. Lovell, if you are ready, you may begin. And Alison, can you hear us?
She still has herself muted, I think.
Are we able to unmute on our end, Angelica?
Allison, if you press *6, you can unmute
I did.
yourself. Oh, here we
I've done that. Are you guys able to hear?
Yes.
Yes, ma'am.
Great. Thank you.
Okay, thanks. It keeps telling me the host has muted me after I unmute, so I think
Oh,
something
I'm
weird's
sorry
going on.
about that.
No, it's okay. I think the connection's on my end because it's kicked me off 3 times since I've started. It just off Zoom, so I'm not sure what it's doing. I apologize if I drop off. But hi, everybody. My name's Alison Lovell. I'm the Business Operations Administrator over here at the Advisory Council on Indian Healthcare. And just to provide some additional context, I come from Access and an MCO background and from a hospital background. So I previously was the Policy and Education Manager over at our state Medicaid program for about 5 years. And prior to that, I worked in managed care organizations, and then I also worked at a hospital, actually. So I'm an emergency medical technician and a wilderness EMT. So I have a little bit kind of across the board on a few of these topics. So the area that I was asked to, really kind of focus on and talk about was when it comes to data availability in this particular spectrum. And there's definitely a lot of barriers that occur when it comes to data regarding children, pediatrics, infants, mortality, anything that has to do with that spectrum. We do have a lot of challenges with data, and there's quite a few reasons for that. Namely, a lot has to do with healthcare claims, to be quite honest. So when you have any individual who receives care at an Indian Health Services location or a 638 clinic, are you guys all familiar with what those are? If not, I can take a moment to explain.
I'm not.
Okay, thank you, David. So Indian Health Services offers, and Dr. Molina actually, I believe, used to work for Indian Health Services, but they offer healthcare across the spectrum to all individuals who are American Indian or Alaskan Native and registered to a federally recognized tribe within the U.S. and to certain designated family members. That being said, in 638s are clinics or hospitals that provide health care to individuals as well, but they are operated by their specific tribes. So think of Indian Health Services as hospitals and clinics that receive funding on a federal level to provide health care to American Indians and Alaskan Natives, whereas 638 clinics operate under something called Public Law 638, which allows the tribe to receive those funds in lieu of an IHS facility being set up near there to be able to provide those services. So they receive those funds and they run the clinic or hospital themselves. So it becomes operated in that manner. So one of the things that can make it challenging when we're looking at pediatrics or adults, honestly, is when you have individuals who are on Medicaid, and I'm specifically speaking to just the Medicaid population at the moment. When we get claims with the state Medicaid system from those hospitals, typically they come with something called a revenue code. And I know when people think about healthcare claims, you think, oh yeah, they're going to be pretty specific in terms of what service was provided. Those individual CPT codes or HCPCS codes, they're either, numbers or alphanumeric, and they come in and tell you very specifically what service specifically was provided. The issue here becomes that an IHS and 638 provider can bill something called the all-inclusive rate, or the AIR. And the AIR is basically a blanket code. They're called revenue codes, and they get submitted for those qualifying services, and there's a lot of qualifying services, as a single visit. So I'll walk you all through an example. Say I go to a 638 clinic and I present with, some mild chest pain, some coughing, but I'm really feeling lethargic. I'm having, issues when I'm trying to walk around. So I have, exhaustion upon exertion, and I present at the clinic that way. My provider is going to go, ooh, you're having chest pain, your pulse ox is a little bit low. We're concerned about a pulmonary embolism. And they may send me for a CT scan to make sure I don't have a blood clot in my lungs. They may, they'll do the actual clinic examination, like the actual provider visit. They'll probably draw some blood work. They may want a chest x-ray. They may want to do all of these things. However, if I had been seen at a provider that was considered a fee-for-service provider, all those codes for all of those things that were done for me would be sent to the insurance for claims processing. But since I was seen at a 638 clinic and they bill under the all-inclusive rate for that service, the only thing that the state Medicaid system is going to receive is a 3-digit revenue code. And that's it. So if we're attempting to take a good, accurate assessment of what healthcare services were provided to American Indian or Alaska Native children, many who are seen at an Indian Health Services or a 638 clinic or hospital, the only information we're going to be able to get by claims review is they were seen. And was it a clinic visit? Was it a dental visit? Was it a pharmacy visit? We're not going to get that specific information, which is a huge limiting factor when we're trying to use data to advise public health decisions or resource allocation. And that is a good example of something that was meant to ease the burden of billing for the IHS and 638 system, but it has downstream repercussions in terms of a systemic problem that could actually result in tribes, frankly, being overlooked for potential opportunities, for things like grants, for things like additional funding. There's a lot of missed opportunities there for tribes and for American Indians and Alaska Natives to potentially receive additional care, to potentially receive, more more resources for things that are reported for pretty much anybody who's seen at a fee-for-service provider. But if you're seen there, you miss a lot of those data points. And I don't think I need to tell this group how important data can actually be when you're looking at any type of decision with healthcare, public health things, resource allocation. So I wanted to point that out as a limiting factor when it came to our particular population. And that obviously greatly affects pediatrics because pediatrics are a very special population. If it can go wrong, it will go wrong. And that, unfortunately, is a great systemic example of how disparities can exist, and they can go unseen for a while. The other thing with data is, there are mandatory reporting requirements for certain things, certain elements of, mortality, and depending upon, what hospital you go to. So say you're at a hospital in Phoenix and a child unfortunately dies. That information is going to get reported to the Department of Health Services here in Arizona, and they have infant and child mortality task forces and review teams. And they're actually they're very interesting because there's quite a few different review teams. First, the first level we have is county level. So counties, they do attempt to partner with the tribes, and some tribes do participate with them, but not all of the tribes participate. So that's a missed opportunity for collaboration when it comes to identifying specific pediatric issues that could occur. And I believe there's 10 countywide review teams for infants and children in Arizona. because a few of the counties are grouped together. Then the second layer of review is the state level, and they have 3 separate ways that they actually review things. They do things on a yearly review is the big one, and they put a report together regarding all the different mortality rates that they've seen, all the different accident rates. And the reason I mention this is that even though I've just explained all about how we're actually missing a lot of data points when it comes to pediatrics and infants, children, when it comes to American Indians and Alaska Natives, even though we're missing a lot of data points there, when we look at the statistics that are reported on those reports, there are huge health disparities already prevalent on those reports, even though the data is underreported for these reports. So that's definitely we're already able to see that it's a huge issue, but it's actually even bigger than what we are aware of. And the reason it's even bigger than what we're aware of is, again, because we don't have all of those data points. Tribes are sovereign nations, and they can choose to report data as they wish in certain elements. So I did just want to provide a little bit of that context and really, hey, this is what we're missing. These are elements that we're missing, and this is potentially preventing us from addressing health disparities that exist. We may not even have all the health disparities identified for this particular population. So in terms of, I know one of the questions that Anna had presented when we first were speaking about this was, what can be done to minimize or eliminate these racial or ethnic disparities in the pediatric health here in Arizona? Collaboration, inviting tribes to have a seat at the table at these child and infant mortality task force review teams, making sure that they are included in these conversations so that everyone is able to have some more transparency on these items, and so everyone can understand how the data is being used and why data reporting is important to ensure that resources are being allocated to everybody that really needs them. So that was really just the part that I wanted to emphasize regarding this discussion. And are there any questions on that?
Thank you. We'll take questions at the end, but did you have anything else that you wanted to add on other topics? Or are you finished?
Yeah, that was the only thing that I was aware I was speaking on. I can add additional context and other things if you guys would like.
No, I just wasn't.
Okay.
I just wasn't sure if you were pausing to take questions before moving on, but that's great.
I could add a little bit of additional context really quickly. I will say, when it comes from the EMS aspect, I do volunteer EMS now. I don't work in EMS, but I do volunteer EMS. And I will say, one of the things that I have noticed, and one of the things that just kids I've mentored have mentioned to me, is that anytime they pretty much have an interaction with the healthcare service, it can wildly vary, to be blunt, based off what you look like. I've experienced this as well as an adult. I know I'm not pediatrics, but I've had kids I mentor who are teenagers who have reported the same thing to me. So I'm mixed race, but I look white. I'm white passing. And I have been, at doctor's offices before, and the doctor's office has been proceeding completely normally. And then there will be a point of no return, that I like to call it, where they will stop and actually look at my medical chart, and they'll go, "Oh, you're mixed race." And they go, "So tell me about your drinking." And that's unfortunately an exact quote that I have had said to me by multiple providers. I don't drink. My sister died of alcoholic liver cirrhosis. So that's something that I, as an adult who can navigate the healthcare system very well, has encountered. Kids I've mentored who are teenagers and who are American Indians have told me they have encountered that as well. And I can tell you, I never set foot back in those provider offices again. Especially considering, I was there for just like an annual checkup or for like a respiratory infection. And I can tell you that when providers treat teenagers like that, that leaves a huge impression upon them, because they're going to be less likely to utilize healthcare services. Just imagine that happening as a child or a teenager. You're not want to go back to the doctor. You could have something very, very serious wrong with you. And it's so important to have that representation of American Indians and Alaska Natives in healthcare, because it helps to foster more trust, because so many people do have that experience. So I just wanted to kind of throw that out there in terms of the context for the discussion, because I think a lot of times, unfortunately, every so often you hear, "Oh, well, the healthcare system is changing." And yes, it is, but it's baby steps. So there's definitely a lot of, things that need to occur to make teenagers and children feel safe. They need to feel safe accessing the healthcare system, and they need to feel like they're not going to be attacked when they go in. They need to feel like comments made to them are appropriate, and that they frankly are not prejudicial comments based off their background. And that, I think, is something that it's a difficult thing to talk about. It really is, but I think not enough people do talk about that, and it continues to happen. So yeah, I just kind of wanted to throw that out too in terms of the context, because that definitely is a systemic, issue that continues to be pervasive, and it definitely it results in barriers, and those lessons stay with people for life based off how they're treated when they're young. So I don't know if that's the kind of thing you were looking for, but yeah.
No, that's very helpful. Thank you for providing that perspective. Well, thank you. And again, are you able to stay on through the final presentation so that we can ask questions at the end? Great.
Yeah.
Thank you so much. Really appreciate your time. And then finally, we have Gerilene Haskon, who is the Tribal Liaison at the Policy and Intergovernmental Affairs Department of the Arizona Department of Health Services. So Ms. Haskon, when you're ready, you may begin.
Okay. Good afternoon, everyone. My name is Gerilene Haskon, and I am the Tribal Liaison at the Arizona Department of Health Services, and I'm also a member of the Navajo Nation. I just wanted to share a little bit of information on questions that were asked are there racial, ethnic disparities within the provisions and access of pediatric healthcare? Yes, we wanted to share that the community of color are less likely to have health insurance, but also access to preventative care compared to white non-Hispanics. And there's also disparities related to the pediatric oral health care across communities that are below the federal poverty level, but also belong specifically to the community of color. I also wanted to share that we have conducted maternal and child needs assessments, and that also includes needs assessment that were conducted by the Navajo Nation and also the Intertribal Council of Arizona. And basically within that information, the findings are that the 6 highest need primary care areas based on the primary care index are all tribal. Navajo Nation, Tohono O'odham, White Mountain Apache tribe, Wallapai tribe, San Carlos tribe, and Colorado River Indian tribe. I also wanted to share that 12 of the Arizona's medically underserved areas lie within the American Indian tribal lands. One of the things that was asked is what area of pediatric healthcare do these disparities exist? And it's really within the preventative healthcare, oral healthcare specifically related to tooth decay and cavities, developmental testings, but also pediatric and adolescent mental health, and transition from pediatric to adult healthcare services, and also just conducting or establishing a medical home. One of the things that we've also seen within COVID was the childcare need, and then recently was the STI testing and treatment within the adolescents. Teen birth and child vaccination. Those are things that exist within the disparities for American Indian Alaska Native population. If there is anything that is very particular disparities within a specific group with American Indian population, it would be that the children's with youth with special health care needs, they experience a wider gap in accessing medically adequate services due to the health professional shortages. And also many of these tribal communities within the 22 tribes are located in rural communities. And so having the ability to have that access and transportation to and from specialty services are very limited. And those are things that we also wanted to discuss is really prevalent. Disparities are really prevalent also within the general pediatric healthcare providers. Arizona needs an additional 558 primary care physicians, 381 dentists, 178 psychiatrists to really eliminate the healthcare professional shortage areas within Arizona. And then also just that minority children are underserved in finding a pediatrician accepting new patients just because the lack of private insurance and also within the rural communities, they're very limited, especially, for example, La Paz. A lot of individuals that may be living in those areas do not have access to a pediatrician, and the closest pediatrician that may be available would be in Kingman, which is very similar to what is happening within the tribal communities, is the availability of pediatricians, but also OBGYNs. And so, in addition, what are the factors that contribute to these racial ethnic disparities is really financial barriers, language barriers, cultural insensitivity. One of the things that Alison and Dr. Molina spoke about is that that language barrier, but also that barrier in that we're in a day and age right now where, as I can explain, that both of my parents don't speak English. So I have to provide them that translation, but I don't have that medical background to provide that to them. And when we are to go off the reservation to receive specialty services, the lack of knowledge related to what type of translation can be provided and the time and of understanding of when that is needed, it really lacks within that. But also one of the things that we also talked about was we wanted to look at any cultural differences really related to cultural competency in healthcare providers, implicit bias training, and trauma-informed care. Many of these individuals that go and work within the Indian Health Services are really providing their services for their loans, and a lot of them spend 3 to 4 years within these areas. So building that trust and relationship, once they build those, they actually have to leave, and so patients are very not trusting within that really cycle system that comes into play. And so a lot of members don't really want to actually take their children or take themselves to get the medical services that they need. What might the current structure design of pediatric healthcare contribute to these disparities is really the limited safety net providers. Arizona has not expanded the Medicaid, leaving a gap in coverage for low-income families. And also just the language accessibility, the limitation of availability of interpreters, translators, or materials that are open to non-English speakers, and understanding the diagnosis and navigating the healthcare system. If you don't know about the healthcare system within the Indian Health Services and 638 facilities, and that's all you've known growing up, just imagine how the Western healthcare system is when you go out and seek care. Provide you an example, Indian Health Service is very a comprehensive healthcare system. So you go to one building, you receive your labs, you receive your pharmacy, you also see your medical doctor, you can get your eyes checked, you can also get dental. When you go into the Western system, they don't have that ability to do that because everything is within different areas, different companies. There's the lab that you have to go to. There's also other, depending on what contracts that they have in place. So those are things that I think learning how to navigate those is going to be difficult for young parents, but also for elders that are going on and off the reservation for seeking services. And then also just the provider and facility distribution. It's very few specialties, as I've stated, requiring families to travel longer distances for these availabilities. And then also just if Arizona has a sufficient data system, what we see from ADHS is that we have sufficient data to be able to identify the racial and ethnic disparities in pediatric healthcare. We have access to routine population surveys that capture met and unmet access, collects medical claims information. But I think what the gap is the siloed system of data systems that are not linking across one another, making it challenging for us to make a comprehensive picture of the status of the pediatric healthcare in Arizona. We benefit off of Concentra, which is Arizona's healthcare information exchange, but we do not receive data from healthcare providers and facilities located on the tribal lands, such as the Indian Health Services facilities and the 638 tribal healthcare systems. So the data that I'm sharing with you does not include any of the data that we would be able to receive if we could from the Indian Health Services or from the 638 facilities, and that includes a lot of that adhering and honoring that tribal sovereignty. So if we're wanting to get Pacific understanding from the tribe, it would be really good for individuals to work directly with the tribes and their public health system and their healthcare systems. And one of the things that we also wanted to share is that, is there anything that has been done to minimize or eliminate racial healthcare systems? Is really just the pressing healthcare needs identified through the tribal community forums that we conducted related to access to care, including family planning, access to prenatal, infant, child, and adolescent care, but also a huge need within mental health access, oral health. One of the things that they've shared is that when right now certain Indian Health Services is not making any additional appointments for mental health, just because there's a huge need within the community and there's already a wait list for those individuals to be seen. And so just increase behavioral health care would be very helpful. Telehealth would be very helpful. That would be able to provide to our tribal members, but also current health priorities within their communities is maternal child health, but they're very limited or no deliveries within tribal communities. There's a lack of OBGYNs that are available. Women are being referred out to the cities. And one information that I can provide is that if there is a child that is in need, special needs, or an infant that is needing NICU services, those services are off the reservation. And here in Tucson or Phoenix, that are flag staff that are receiving those services. But the lack of transportation, the lack of access to resources that may be available increases the mother's mental health, but also the communication also between their on reservation, off reservation, very limited as well. And within the data that I've been looking at, we will have a new American Indian Health Status report that will be coming out. And that's very focused on childhood injury. That is huge within our American Indian population. Childhood injury within motor vehicle accidents. Those are one of the things that I've seen that has increased within the past year. So thank you.
Thank you so much. Really appreciate your remarks. And I want to thank all three of our panelists for speaking today and providing remarks. And now we will open the floor to committee members who are present to ask questions. So each committee member will initially be limited to one question and a follow-up. And then if time allows, we'll go around and allow for additional questions. And just a reminder that Q&A is reserved for committee members only, and committee members have to be recognized by the chair before asking any questions. And then again, I'll ask for follow-up questions as time allows. So what we'll do is first, I will just call on each member present and ask if you have a question, and then we can have, again, if we're going to do follow-up, we can have folks just raise their hand. I'll go ahead and start. And just as a reminder, please feel free when you ask questions to ask questions of one of the speakers, multiple speakers, or all. I am actually going to ask my question of Dr. Molina, although if others panelists have comments, please feel free to add on as well. But Dr. Molina, you mentioned a number of serious issues that need to be addressed, issues of mental health and cultural identity and obesity. So just a wide range of really serious issues. One of the things that we're trying to do as a committee is come up with some potential policy recommendations, primarily federal policy recommendations. But I was wondering if you had any policy recommendations in mind that we could recommend that the commission consider or that Congress would consider in order to address these serious issues.
Sure, absolutely. Thank you for the question. The issues that I address, and I appreciate my colleagues also touching on other issues, because this can be such a complicated field when we're looking at being able to impact some of these serious consequences that we see. For me, it's always been about, and it was mentioned, is about how do we sort of streamline the system so that we can make up for some of these gaps that exist. I think Gerilene had a really good presentation on the different gaps that exist and, having to go from one provider to the next provider. From a policy perspective, I think it would be sort of good to see how the American healthcare system can become more integrated. I think integration is a big thing to help bring sort of all these different pieces of the puzzles together to make it easier on patients to access the care that they need. Primary care integration is a big one. The integration of behavioral health services within the primary care setting would be something that would be sort of as a matter of policy to embrace and suggest and recommend and maybe really have these primary care provider groups that receive federal funding to begin to integrate, their system of care, maybe beginning with behavioral health services. I know at the Urban Indian Clinic in Phoenix, we have an integrated care counselor that is part of the medical team that is there to help some of the issues that do come up, especially with pediatric people. And we have, as part of the integrated team, care coordinators to help navigate the system as best as they can. The other thing that I think would be critical to look at is, there was an effort a couple of decades ago where providers, especially, primary care providers, pediatric providers, were mandated to attend cultural competency training as part of the reimbursement for Medicare and Medicaid. But I think cultural competency, although it has made some difference in being able to educate providers on cultural differences and embracing maybe trauma-informed care, for me, it's really maybe more looking at cultural humility training. This is something new that I think goes beyond cultural competency, but it really enhances a provider's ability to do a lot of retrospective thinking about the culture that they're taking care of. Because as Gerilene and Alison mentioned, a lot of our providers have these assumptions and biases about our people. And I think that being able to move forward on, maybe requiring this kind of training, especially for, groups of practices or hospitals that receive federal funding, to incorporate this training into for the providers that they employ. Just a couple of thoughts.
Thank you so much. All right, I'm going to move on now to David Kim. David, do you have a question for one or more of the panelists?
Yeah, so let's see. Yeah, so I guess, by the way, thank you, Dr. Molina. That was very constructive input on potential policy changes to the system to better support the Native American communities. Maybe I could pose a question to Ms. Lovell. She mentioned during her presentation that there are disparities, and one of the ways to overcome that disparity in her view was through collaboration and making sure that they're included. I mean, those words and statements resonated with me, but I was wondering if in your mind, Ms. Lovell, whether there are systematic obstacles towards this type of collaboration that you think would, work to reduce disparity.
Thank you, David. Yes, so there's actually, there are quite a few obstacles. In fact, our team here at the Advisory Council is having an entire epidemiology summit to discuss those different kinds of obstacles that occur. But first and foremost, I think the first obstacle would have to be establishing trust between tribes nationally and entities that collect data. And that is definitely going to be an uphill battle because there has been very recent breaches of trust of that. There's been instances in very recent history where data was, gathered from tribes under one particular guise, and then it was used to basically invalidate their beliefs. A very famous example here in Arizona is Havasupai tribe. Blood samples were taken and data points were collected to, do data research in one area that the tribes had been very much in agreement on. And then the university that had gathered them, from my understanding, I wasn't in Arizona at the time, but from what I understand about it is that there was like ancestry data and some attempts to determine, hey, where are these different genes from? And no one in the tribe had consented to that. So when it comes to the systemic issues, first is going to be establishing that trust, and that means having a seat at the table. As far as I know right now, there isn't even a state data collective. That's something actually we've been talking about, seeing if we could potentially form, because it's an identified need. Frankly, it doesn't exist right now, where all the different tribes could potentially come together and have a seat at the table with counties that collect data and states that collect data. I realize that would be a very huge undertaking, but until something like that happens on a national level, it's going to be really difficult for people to have that face time together and to have any opportunity for trust to get built. There are tribal epidemiology centers that exist throughout the country, and that is great, and it definitely helps. But in our conversations with the different tribal epicenters, we have a senior epidemiologist on staff, and he has, mentioned from his conversations with them that they're limited with the type of data that they collect. And every tribe is a sovereign nation, so they have the independent authority and right to determine what data they're going to provide. But I think if we, provide context of, hey, here are the resources that could be provided if we had a better idea of, hey, what social determinants of health are, the most gregarious, or hey, here are different, chronic disease and acute disease indicators. There just needs to be some type of way to open the pathway for discussion, and tribes should not be mandated, obviously, to provide data. That would be absolutely out of line. But if there was a way to perhaps, allow sharing of aggregate data points, for example, hey, from our data collection, here is what we have observed. This is what we could use help with. And I think if tribes are allowed to do that, as opposed to, hey, you give us your data, or you're left out of these potential grant opportunities, or you're left out of these other potential discussions, or you don't get a seat at the table. I just feel like there's a lot of that occurs right now, where it's kind of an all or nothing thing. Either you're going to share things or you're not, and if you don't, you're kind of left out in the cold. And that doesn't really work, because again, there's a lot of missed opportunities for tribes then to participate in, grant writing is the thing that popped into the forefront of my mind, probably because we were grant writing this week. But there needs to be ways to allow tribes to apply for things like grants a little bit more easily in terms of a systemic thing, without providing a ton of those data points as a part of the grant application. I'm just going through our own grant application right now that we're working on. We had to look at a bunch of aggregate data that we have available and say, okay, here's the health disparities that we were able to accumulate, but we're missing a lot of data points, obviously. So that could go against our grant application. That's just one example. And for tribes that have access to considerably less data, that's going to, put them at a disadvantage when they are applying for grants, or when they are trying to get additional resources to their communities. So from a systemic level, I think I kind of rambled a little off tangent there, but from a systemic level, giving everybody a seat at the table, finding a way to give everybody space time together. That is so important. I realize that's ironic because my webcam on this computer does not work, but giving people that space time together so they can get to know each other and get that sense of community, that sense of building trust together, because that's going to take a while to rebuild that sense of trust. All it takes is one instance for trust to be lost for a generation. I mean, that's all it takes. And it takes considerably longer to rebuild it. And that, I think, has been something proven historically worldwide. So yeah, I think we just need to have some kind of systemic way to allow tribes to have a national seat to discuss, hey, here's our issues, and here's our barriers, and here's our best practices with our data, without the onus of making them feel like they have to share their data, and then saying, okay, here's some ways to streamline your ability to have grants, your ability to receive resources, even though your data points are being left out of different areas. So yeah, from a systemic thing, it's challenging, but I would just say, something to provide everyone a seat at the table, and to provide everyone an easier way to have resource allocation without being forced to provide data, especially given the recent and the historical traumas that have occurred with that.
Thank you, Ms. Lovell. I think that was clear. I think I also appreciate the second point you made, which is, one, because of the sort of the coding system, that it's difficult to provide a precise data. And due to sort of the lack of precise data, the tribes are missing out on these grant and special help opportunities. So it becomes vicious cycle. Thank you for the input.
Oh, you're welcome. Thanks for the question.
All right, thank you. We'll move on to Jonathan Rose. Jonathan, do you have a question for one or more of the panelists? I think you're on mute, Jonathan. I think you're on mute.
Okay. I actually have two for all of them. I'll ask one now and another if we have a chance. One of the problems that Ms. Haskon referred to, and that we've heard testimony before, as well as newspaper articles, are the significance of the changes in Medicare eligibility after COVID. I wondered if anyone has collected any data to specifically show something about those results and the way it has limited the availability of healthcare, and with particular reference to pediatric care, and whether there are any efforts underway to reverse that decision and try to restore a broader eligibility to Medicare. That's for all three of the people if they want to respond.
Just chime in right now. Thank you, Professor Rose. I think, let's say the emergency ended. It's been almost a year now that the emergency has ended, and I don't know through our Medicaid claims, Alison, how much data has we been able to look at resulting from the Medicaid claims that we've seen coming through our agency.
Yeah, so can you guys hear me? My phone did that weird thing again.
Yep, we can hear you.
Okay, fantastic. Yeah, so just from the claims data we've been able to look at, and to provide some additional context, when it comes to looking at our claims data for Medicaid claims, but again, this could potentially be an issue for other healthcare providers too, depending on how claims are submitted. You can only gather the data that's reported. And I don't know how many of you on the call have recently looked at a healthcare claim form, either a UB04, which is called an institutional claim form, or a CMS 1500 claim form, which is the professional claim form. But unless you're a professional biller or coder, it may not make a whole lot of sense. So when it comes to the data that we have looked at both the institutional claim forms and the professional claim forms. We looked at any claim that was submitted to Access Fee-for-Service for Medicaid members who had an American Indian or Alaskan Native indicator. And in those data points, we were able to find a lot of different health disparities. And I apologize, I'm trying to pull up the statistics on these right now for you guys so that I can give you the precise statistics here. But just from what we were able to look at, and again, this is very incomplete data, I want to emphasize that, because it's missing a lot of information when it comes to, those UB04 claim forms billed with AIR. But we were able to find that for American Indians and Alaska Natives during COVID, if someone had a social determinant of health that indicated that they smoked, they would be 4.58 times more likely to get pneumonia as a result of it. If they used smoke or nicotine, they would be 3.5 more times to go into respiratory failure. And as we all know, once you're in respiratory failure of COVID, you are pretty likely to die. Moreover, we were able to look at other social determinants of health, things often outside of people's control, like secondhand smoke. Some people get exposed, at the workplace or from family members. And people who had secondhand smoke exposure, and did not smoke themselves, 3 times more likely to go into respiratory failure from COVID. Other things that we were able to look at, lack of exercise, 3 times more likely to get pneumonia if you did not exercise the recommended amount. And if you're not familiar with the recommended amount of exercise, it's 75 minutes of vigorous activity. So, you're looking at 60% or more of your, maximum heart rate, or 75 minutes of that, and then 100 or 150 minutes of, low to moderate intensity. So when it comes to exercise, most people are not getting that. And if you look at the actual, sports medicine guidelines, you really should be getting about 300 minutes of about moderate exercise every single week. And I know very, very few people who actually get that. I tend to exercise a lot, and not recently because I've been sick, but normally I do. And even on a week where I try to, and I wake up, between 2 and 3 a.m. every morning, I still struggle with that. So this is a very common problem for individuals, lack of exercise. And when you think about the other compounding social determinants of health, such as a lack of exercise, lack of running water, lack of paved roads in rural areas, all of those cut down on somebody's time to take care of themselves, to be able to get exercise in, to be able to engage in those healthy habits. It's basically a domino effect of things. So when it comes to COVID, and I give you this contextual background, when it came to COVID, we were able to take a look at reported healthcare claims based off diagnosis codes and based off social determinants of health diagnosis codes. Because as I mentioned before, you don't get a whole lot of information from those revenue codes. And for our American Indian and Alaska Natives in Arizona who receive those services from an IHS 638, we're usually getting revenue codes that are billed as all-inclusive rates. So we don't get a whole lot of information. So we have to go by those ICD-10 diagnosis codes. And that's what we tend to look at. So you can do those comparisons of social determinants of health against the other outcomes. So we could go, hey, respiratory failure diagnosis code, and is there a social determinant of health of lack of exercise? Was this something that showed up on that individual's, medical claims before they got COVID? So you can do those kind of cross comparisons, but it's mostly going to be based off those ICD-10 diagnosis codes because of those limitations we mentioned earlier. So you can do cross comparisons with the data that's there, but again, the data is very limited. But even with the limited data that we did have, we were still able to make a lot of unfortunate conclusions based off, a lot of the lack of resources in tribal areas because of those historical traumas, because of people being forced to move to, outside of their ancestral homes, because the people not having equal access to resources like running water, for example, you automatically lose out on the opportunity to engage in a lot of these, these beneficial activities that could help you. What's that?
I just had a follow-up. Has there been any attempt to contact the various tribes to identify people who no longer have medical care because of the changes in Medicaid eligibility?
So the Medicaid, I guess I'm not really understanding the particular question. The state Medicaid department has done a lot of outreach via mail to individuals who were going to lose their Medicaid eligibility.
I am not aware of any of the patient navigators or individuals that have been working on the tribal communities, but not aware of what tribes have been doing at the local level.
Yeah, and I want to say, Allison, that it seems to me, and I don't know where I saw this, but after the public health emergency ended and things started to change and people needed to update their registration, otherwise they would lose it. It seemed to me that there was a drop in the number of new applicants for the Medicaid program. At least that was the experience that we saw in Native Health, just by means of the number of visits that were coming through and were then billed under the Medicaid program. But I'm wondering if there was a trend in the drop of claims that came through after the public health emergency ended, and people were then required to register for the Medicaid. I don't think that federal poverty level was changed. I think they just needed to re-register again, and I think we saw that drop. And maybe I'm misspeaking, but that's kind of what I sensed.
It
The other
just,
thing too that makes it difficult to judge by is, again, IHS and 688 providers, they have 12 months to submit their claim, their initial claim. So say I was seen before the public health emergency ended, like earlier last year. So theoretically, Access could still be getting claims in right now for claims that were valid during the public health emergency. So there's a whole year, of time that could go by. And I can tell you from when I worked at Access, that happened a lot. You would get claims that would come in at, the 11.5-month mark. And that would be the first time the claim would come through, because IHS and 638 providers have the right to do their initial claim submission within 12 months of that date of service. So there's not exactly a quick turnaround in terms of being able to look at those trends. By the time you look at trends, it's going to be a year out. And those renewals and determinations, we're not even in that time period where we could actually even fully gauge that quite yet because of that delay. There probably is going to be, like my feeling, Dr. Molina, I agree with you. I think there's going to be a drop. I think that there definitely, is a slope that's occurring. I just don't know if we're going to be able to see that until we, pull data maybe 6 months from now. We might be able to start seeing that trend.
thank you.
All right, thank you. We do have time for additional questions from members. So I'm actually going to begin, and I'd like to ask a question of Ms. Haskon. You mentioned a number of shortages of physicians and medical professionals. Some of the numbers that you provided were quite high. And you did talk about a couple of recommendations. I know you mentioned telemedicine could potentially help bring some of that down or make that a little bit more bearable. But of course, some of those appointments are going to have to be in person. And so I'm wondering, along the lines of the earlier question I asked, do you have any specific policy recommendations that that we could pass on in our report to try to address some of those shortages?
So one of the things we have a primary care office, and within that, they lead a statewide effort to improve access to care to all services. And they provide federal funding, which is the state loan repayment plan, the National Health Services loan repayment program, and also the Conrad 30 waiver program. And those are one of the things that I feel like more policy is just increasing those. That way that availability is available for additional providers, because right now we're only obligated to provide 133 providers through these programs. And if has been an increase in funding, that would allow more individuals to be in these areas where their professional shortages are.
Thank you. All right, I will go ahead and open it to if there are other members that have questions. And Patty, I see you joined us. I know that you just joined us, and so I certainly don't want to put you on the spot or expect that you would have a question, but I do want you to know that I see you, and if you do have a question at all, please feel free to let us know. But otherwise, if Jonathan or David have any follow-up questions, please feel free to raise your hand. Yes, Jonathan.
Professor Rose, you're muted.
I'd like to ask all three speakers today to what extent they consider the availability of prenatal care as important in understanding racial disparities in pediatric care.
Thank you, Professor. Maybe pick off that conversation as an overview. Let me get here.
Dr. Molina.
Yeah.
It's pretty choppy.
Or is it?
Okay, how about now? So a little bit better? Okay. Well, let me give you my experience as an OBGYN. For one thing, in the traditional way of life for indigenous people, birthing is very sacred. It's done in very many types of sacred ceremonies. And when I was at the Indian Health Service, delivering babies, it was just an honor and pleasure to see how our Native women looked at their pregnancy. And I think that in general, Native women are very aware of the importance of the pregnancy, taking care of themselves, adhering to the best kind of a health practices to ensure a good health outcome. The issue that I saw is that, again, it goes back to the trust that they have in providers. And if there's not a trust relationship between the OBGYN physician or the doc and the patient, then you might have issues of non-compliance. Not wanting to go back to follow up with a visit, not following through with recommendations from the doctor, especially if it's a high-risk pregnancy. A lot of our women came into their pregnancy with diabetes or developed gestational diabetes, and these were high-risk pregnancies. And what always concerned me, and I felt that honored that a lot of our women were coming to the Phoenix Indian Medical Center, well, they're able to go to a tribally managed facility for their care because they trust that system. Because outside of that system, there was not that sort of sense of trust, if you will, that we've talked about a little bit. So that's why I feel that some of the issues have come up in sort of what we've seen as the increasing rates of maternal morbidity and mortality, is that issue of trust, of having a provider that they can confide in and feel that they've validated in terms of how they look at their pregnancy. The other issue that's come up has been sort of in the rural areas, access to those specialty care. Now, it's, thank goodness that, most women can have an uneventful course of pregnancy. And that's why a lot of women, if they don't have that access to care or trust with a provider, they probably won't go to the hospital until it's time to deliver the baby. So I think between developing the trust of the provider and having an access to specialty care, especially in the rural areas. Now, Gerilene mentioned that, there's such things as telehealth now that can be utilized to be able to bring in specialty care by telehealth with a primary care provider and joint practice. So that's one of the opportunities, is being able to advance, hopefully, a telehealth capabilities through broadband. So I think that would be great. But just to close off, and maybe Gerilene and Alison can chime in, is that I had an experience when I was delivering babies in my community of Guadalupe. We finally left our practice in the late 2000. Is one of my clients came to me 10 years later and said to me, Dr. Molina, I really enjoyed you as being my provider. And she had 3 babies while she was under my care. But the statement she made later kind of surprised me. She said, after you left your practice, I didn't want to go anywhere else. So I had my tubes tied. I wanted to have 6 children, but I only had 3. Then I had my tubes tied because I couldn't trust any other provider. And the trust is not only in the provider, but in the system of care, that the patient feels safe, they feel comfortable. And so I think that's what happens, is that element of trust is not there. But the story with this patient is she went on to adopt 3 children in order to complete her set of 6 children. But I think that was a very strong message that came to me, that we really need to enhance that maternal care with being able to increase access to care and being able to educate OBGYN providers in trauma-informed care and cultural humility to be able to gain the trust of the women that we serve. And I don't know if Gerilene has other thoughts about that too.
I believe that David has a follow-up.
Yes, Dr. Molina, thank you very much for your sort of answer to the question. I guess I would have a follow-up question. And I think I know the answer to this, but nevertheless, I think it's worthwhile asking, which is, I myself and my family also go through a fairly difficult process when I go to physicians. I think 9 out of 10 times we kind of go through humiliation. and also what we feel like incredible level of frustration, lack of sensibility towards cultural, ethnic differences, but also just, I think, just the medical system. It seems they don't have much of a humility or compassion that's needed. Do you get the sense, Dr. Molina, there has to be a training or awareness that just goes beyond all the medical professions that deal with all different types of clients and the patients, or is your position sort of like, hey, we just need to have a more enhanced and compassion and humble medical delivery system for everyone, including Native Americans?
Yeah, I believe that we need to look at our system of medical education because it's still very paternalistic sort of training. And I think one of the opportunities that we have is to engage in cultural humility training across the board, that would begin in medical school. This is where we can begin to engage these young people in terms of looking at the holistic approach to care, understanding cultural differences and the impact that it could potentially. This is probably covered during the first 2 years of medical school when you're taking your basic science courses. You take behavioral health sciences, you take courses in in being able to improve patient-doctor relationships. But I don't see a lot of that really addresses in depth, this issue of cultural humility, cultural differences, cultural disparities. Health disparities, yes, we can understand as physicians, but cultural disparities that impact, in a wider range, the health of individuals. But more than that, as how can we help our patients feel more a part of that care, respect and understanding and that validation. I see that as an opportunity, as a matter of policy, to begin looking at the medical schools to try to engage them at that point, to address exactly what you're sharing. So thank you.
Thank you.
And I can share, in addition to what Dr. Molina shared, is really what you guys were talking about medical school, really understanding the reasoning why building trust is one of the most important things within tribal communities, but also understanding the worldviews from an Indigenous perspective, understanding that not everybody is very linear. We're very circular thinking individuals, and we think about community first rather than individual. But also just the different historical traumas that have happened related to Indian health services sterilizing our women so we can actually decrease the birth within a lot of our women. And so that is really just those understandings of providing that education to our medical school students, and also just the pain prevalence. I've heard individuals and doctors, even within my own experiences, stating that, oh, you know what? I mean, Native Americans and Black are more likely to not experience as much pain. So you should be okay. So those are things that point blank understanding of really looking at those in things and really the traditional practices. I think the reasoning why there's a decrease in prenatal care within Western culture is just because of that understanding that they won't understand the things that I needed to do, the positive mindset that needs to happen within the delivery room of all people that are in there because of the birth of this child that's coming into this world. That spiritual element within that, understanding that what the baby was in is sacred, the placenta, and understanding that we don't actually burn that, we provide that back to the Mother Earth. We want to make sure that we have those discussions ahead of time with in addition to all the questions that they ask when you're being admitted. Then that's when you ask your questions like, okay, this is what I need to do. These are things that we need to put in place for my sake, for my traditional aspects. But some of these conversations are very new for OBGYNs. Some of these are very new for pediatricians that are coming in to see the child. The pediatrician shouldn't be the first one that would see the baby, right, when it comes into the Mother Earth, because the mother should be the one that would have first access, because that is who is that sacred moment and that sacred being. So those are different type of medical school education that should be provided, but also even within understanding the access to water, access to electricity. When you are providing prescriptions related to medication, or understanding how to take care of yourself, but also understanding that social aspect and that how that person is living. Do they have access to water? Do they have access to electricity? You're telling them to bring back a stool sample. You're telling them to bring back urine sample, but they use an outhouse back at home. So those are things that the type of discussions would be very helpful. If you don't have that background, you're less likely to have somebody come back to you and provide that additional, but also that education related to that. One of the things, I oversaw the maternal infant early childhood home visiting program, and we were able to partner with the tribal communities. And one of the things that the tribe stated is that we had 2 or 3 pregnant women that were from a very rural community, but they wouldn't see access to care because of the local border town community had very systemic racism. And so they would travel at least an hour or 2 to the next available place where they know that they're able to discuss, they're able to become more comfortable to actually have birth there. So that's the reason why Native American women, they go in when they find out that they're pregnant, and then they come back until they're actually going to deliver, because they know the limitations of funding that is available to them to even make that trip down to that community. So those are things that we need to talk about, because Arizona is a very frontier state. A lot of tribal communities are very rural as well. Thank you.
Thank you. Patty, I see that you have a question. Please go ahead.
Yes, thank y'all so much for your testimony today. My name is Patty Ferguson Bonney, and I'm sorry you can't see me right now. But I think I'm following up on Ms. Haskin's question that you were just discussing, and I apologize if this has already been discussed. But given the rural nature of Arizona tribes, and I was just wondering if there are other issues that y'all can highlight that impact access to pediatric health care, how that could be compounded by our reservations being rural in Arizona, whether that's access to transportation, underfunding of the IHS system, whether there are actual, pediatric offices on all of our reservations, or people have to go to, certain IHS facilities, which may be a distance from tribal communities.
One thing that comes to mind.
Oh, go ahead.
Oh, sorry. I was just going to say one thing that a young mother had actually mentioned to me at I think it was at tribal consultation over the summer. She had just been in attendance very briefly. She had come in and then she had come out, and she had mentioned that she just wanted to listen in a little bit. She had been affected by the issue that we were discussing at tribal consultation, but she mentioned it's very difficult for her to get the time to be able to do things that she needs to do. Especially in those rural areas that are lacking paved roads. Even if there are paved roads, it's very remote. So it could take, you may need to take an entire day off of work in order to seek out your child's healthcare and to do wellness visits. So sometimes insidious things that can crop up, like type 1 diabetes or type 2 diabetes for children even, since that's becoming more and more prevalent. And that could crop up and be missed if people are skipping the well visits for children. And a lot of fear, especially if people are socioeconomically depressed, they're afraid to lose their jobs. They're afraid to have punitive measures taken if they need to take time off work. So maybe a potential recommendation could be providing protections for parents to, and I don't know if that's within the context of this conversation, but maybe the recommendation for legal protections for parents to be able to have, X number of days off work with their job staying protected, just to be able to make sure that their child can get those annual, well visits and vaccinations and all of those.
Thanks, Allison. And I was also thinking, it's a great question. Thank you. The pediatric care is actually specialty care. It's especially in medicine. And as specialists, they're a little bit more difficult to get into the rural areas. Being able to, like you mentioned in Arizona, we do find a lot of them in the urban areas like Phoenix, maybe Flagstaff and Tucson. But to get them out into the rural areas is kind of a challenge, and especially looking at an IHS facility, an IHS funded facility, it's even a little bit more difficult because pediatricians actually make a little bit higher income than a lot of the primary care specialties. So IHS has a certain level of salaries that they have for different specialties, and sometimes it's not being able to become competitive to get a pediatrician out in the rural community. The other problem that Alison just mentioned is if they did have a specialty care for pediatrics, being able to get there could be an issue, especially up in the Navajo area and other areas up like in the northeastern part of the state. So just that social determinant of health of transportation would be another issue. But I'm thinking that one of the things that we did talk about here so far is the implementation of telemedicine. I think that has a great opportunity, especially in rural areas where the telehealth system through broadband expansion can be utilized to be able to take the pediatrician, if you will, to the site, in concert with a primary care physician. It can be a virtual visit, with the pediatrician hooking up with a facility, with a primary care provider. It could be a mid-level provider like a nurse practitioner. This would really, really be helpful. The other sort of experience that I've seen is with the tribally managed facilities, Tribal 638 programs, because they're taking over their management of their healthcare system. They really were able to advance their revenue because, a big part of this is IHS funding. The discretionary funding that Indian Health Services ITUs get really doesn't meet the budget demands. But I've seen by experience, and some of you have seen also, that tribally managed hospitals are able to do a lot with their revenue streams through enhancing their coding system, their billing system, being able to contract out like maybe sometimes IHS can't do. So being a tribally managed facility, I've seen that they've been able to support the higher incomes for pediatricians to actually be on site. San Carlos, for example, has pediatricians, and some of these specialists actually will live on site. They have housing that the hospital is able to get for them. So I think tribally managed 6 or 8 facilities do a great job to be able to meet some of the barriers that we've talked about. Thanks.
Thank you. I have another follow-up question. We've just been talking about unique challenges that are faced by people who live in rural areas. And I was just wondering, are there any other disparities that any of the panelists have observed that might be unique to particular tribes?
I think one of the things that we didn't share is that within environmental effects, you related to uranium, especially with the Navajo Nation and Hopi. They have been conducting a Navajo birth cohort study, which is basically understanding a little about the level of uranium exposure or radiation within the infants and children. And so within the study that they conducted, which was with the University of New Mexico, and they did see a huge increase of exposure of radiation within the communities that they were living or areas that they were living in, and also just the birth defects related to those issues. And so those are things I think that would be really good to look at, the environmental factors that are in place within a lot of these individuals. A lot of the individuals that live more under border communities, like the Tohono Nation is really looking at the lead exposure within that, within the children within those communities, but also asthma has been affected just because of the environment related to the coal plants and those issues. I know that I've heard that within a lot of my communications and town halls that we've conducted.
Thank you, Gerilene. The other thing that I've heard and seen is
Transportation related to road conditions. You know, not all roads in the rural areas are paved. And especially when you get rains like we have been for the last few days, it can really make an impact of just trying to get to where you got to get to. And then the other one is having reliable transportation, you know, being able to get through where you want to get to. The other thing that we speak about the social determinants of health, I was just thinking also is of a disruptive family, family violence, substance abuse that impacts the family and therefore impacts the caregivers to provide the care for their children. Like, you know, maybe non-compliance to medications, follow up on appointments, things of that nature. If there's sort of a family dynamics that's disruptive, it's been impacted by alcohol, drug abuse, or domestic violence, these are also issues that impact that caregiver and getting the child to be able to get the care that they need. So that I think would be another factor to look at.
All right, we have time for one more question. Is there, do any of the members have any final questions?
This is Patty. I have just a comment and then maybe a question. One is just wondering whether Ms. Haskon can, if there's any reports from those town halls that could be shared with us, because I know specifically she was at reporting on issues and like the asthma conditions, those might be helpful. And then the other is, you know, the issue of telemedicine and the ability to get prescriptions. I'm just wondering, you know, logistically how that would work. I don't know if Dr. Molina would know, because it seems like there would still be a distance, and if people don't receive mail at their homes, how do they pick up these prescriptions?
That definitely would be an issue if you had a paper prescription or that was given to you. In most cases, a prescription that's written can probably be filled at the closest IHS facility. If they're in the rural areas, most of the rural areas, reservations do have either a tribally managed program or an IHS facility that prescription could be filled maybe a little bit closer. In the rural area, I mean, in the urban areas, it might still be a problem too. Especially if you go to a private care physician that doesn't have a pharmacy, then they're going to refer you out. So then again, it's going to be an issue of trying to get that filled. Maybe in the case of the rural areas, even if it goes to an IHS facility, well, kind of usually, I guess what happens, and I'm just kind of trying to think of how I've seen it kind of pan out. Tribally managed hospitals and programs and IHS facilities are usually integrated. They have the whole clinics and the pharmacy and everything on site. So the patient is able to just get everything done under one roof. So it's usually not an issue, but I guess it would be more of an issue in an urban setting if it was not an IHS facility on how that person might have to gain access to their the medication.
Just if I may, Christina, just following up on the recommendation for telehealth, I guess that would be my question. How would they obtain those prescriptions, or have you seen, do they have to go to the IHS facility, or are you imagining the telehealth at the IHS facility?
I was thinking as far as the telehealth program, it would be where the provider could actually virtually be in the same room with the patient, at least patient care. But if we're talking about being able to send scripts through telehealth, that certainly is possible. But again, I think if you're within the IHS 638 setting, that wouldn't be an issue because the pharmacy would be right there and you'd get it. Kind of like what happens to me. I mean, let me just give an example. I get my care at an urban Indian clinic here in Phoenix. And then what happens, I see the primary care provider, but they don't have a pharmacy. So then by telehealth, they sent the prescription like to Walgreens. So now I've got to go to Walgreens and pick up a prescription. So I think it might be more of an issue. I mean, it's still good that you can send telehealth prescriptions because you get the prescription written at the pharmacy, but the issue would be if you're not within an IHS system like a hospital or a 638 facility, then it might be an issue.
All right. Thank you all so much. We are at time, so I want to remind members that if they want to ask more questions or if you think of additional questions later, please feel free to send those questions to Anna, and she can direct them to the panelists. And we don't have any members of the public that are currently available to comment, but because this is being recorded, I'll just mention that if members of the public want to provide any public comment or have additional comments, they can email their comments to atrevino@usccr.gov, and the comments will be shared with the committee. So with that, I'd really like to thank our speakers so much for attending this briefing. It was very informative. Your perspectives and your opinions are really going to be very important to us as we draft our report. And the committee is going to be meeting in a couple of weeks to debrief on testimony received today. And additional information on upcoming meetings will be available in the Federal Register, or you can contact our support specialist at atrevino@usccr.gov to let her know that you'd like to receive notifications for future meetings and briefings. So this concludes the briefing portion of today's meeting, and we are going to move on now to conducting committee business. So again, our speakers and our members of the public, of course, you're welcome to stay on if you'd like, but it's certainly not mandatory. So thank you again very much for joining us, and I'll give everyone just a couple of minutes to log off if they'd like.
Thank you.
Thank you so much. All right. All right, we can move on now to committee business. So I know we wanted to open a discussion regarding the project, and Anna, I know we want to get some guidance from the members who were able to join today on how everyone would like to proceed. So do you want to kind of walk us through that?
Yeah, I first just want to make a quick announcement, and I don't know if we made it clear during the last meeting, but your chair has sort of taken a kind of a sidestep, if you will, in terms of leading the committee. Unfortunately, Chair Ross has had to deal with a lot of kind of personal matters, and so this is sort of why we've been leaning on other members to help kind of keep this project moving forward. And so I apologize if that wasn't communicated earlier. My second announcement is, let me just double check here to make sure.
Anna, if
sure.
I may, so Chair, Madam Chair, she's not going to be chairperson anymore, or she's not going to be a committee member? It's not clear to
So
me.
she's still going, yeah, thanks for that question. I should have clarified. She will still be on the committee. The way that the commission operates is that if a committee chair steps down, the vice chair will step in to be an acting chair. Eric Yorty is still the vice chair. Leslie Ross mentioned that she has no interest in stepping down as chair. It's just in the interim, she will just be leaning on Eric and possibly Christina to step in for her. She hasn't given me sort of a time frame of her kind of expected, I don't even want to call it absence entirely, but her sidestep, if you will. I'm just coming up with words at this point, but she's still wanting to be active, just depending on her availability. She just doesn't want to be the reason for any delay in the project.
Understood. Thank you.
The progress of the
She's
project.
going to, I don't know that I've seen her at recent meetings. Is she going to participate in our business and other meetings?
As if her schedule allows. So I still consult with her and Eric about sort of, I asked for guidance in terms of how to move forward with the committee. That's sort of the participation so far. This next stage would be the report stage. So she may be contributing in that fashion. I just don't know if she'll be present during meetings, actually leading the meetings. As I do send out these polls to ensure that we have committee attendance. We have enough members in attendance. Unfortunately, today it didn't work out for Eric Yordi because he teaches on Tuesdays. But he also, asked that we move forward, and then they discussed and asked that Christina lead the meeting. So I'll say that in terms of kind of getting guidance, I have been consulting them. They, as far as much as possible, if their schedule allows, they will be participating in future meetings.
When you say the next phase is the report phase, does that mean we are not going to hear any further witnesses?
That's up to the committee to discuss today, and in future meetings, if you think, the information you received is sufficient. And actually that might be a good segue, Christina, because I don't have any other announcements. I was just looking to see my notes, but that was my main announcement about your chair and vice chair's availability and engagement going forward.
Yeah, that sounds good, Anna. And as far as if we want to just move into a discussion on like whether we all think that we have sufficient information and we're ready to kind of move forward to the next step, I'll just put some thoughts out there and then love to hear what the rest of you think. I think we've gotten some really good testimony. I think for me, and I know this has come up a couple of times in our discussions, there's always just been a question of maybe getting more data in certain areas, but I'm not really sure. Whether the data that would like make me feel really good is even available. I know that there's been a lot of discussion about how nuanced data, I mean, we heard a lot of that today, even from the panelists, just isn't available in certain areas. And so I'm not really sure how much more there is even out there for us to be able to collect, and whether or not we would be able to get additional panelists that could provide additional insight into that. So I think I would want to balance that against the fact that we have been working on this project for quite some time now. And it seems to me that unless we think we're missing any like major perspective that we haven't been able to get yet, it's probably a good idea to try to pull together some themes and wrap up so that we can put our report together. So that's kind of my thought. What do the other members think?
Well, I have some concerns about the amount of data that we have. The speakers we've heard, I think, provide two very different kinds of data. Some of it is quite general. I thought Ms. Haskon is the ideal kind of person we're looking for because she had a lot of specific information as it related to tribal communities. That is exactly the kind of information we need on the report. So I'm concerned about the quantity of specific information. Part of it is comparing it to my participation. Believe it or not, I've been on this committee for 10 years. And so I compare it to past reports and witnesses, and I think we have less than we normally do. And so I'm concerned about that. And I'm also concerned about the scope of the report. It seems to me we have much more information on disparities relating to Indian tribes than in general. And although we do have testimony on the impact of the reduction of Medicare eligibility. So I have some concerns about that. I might add, I don't know if this is due to scheduling problems, but in general, and this sort of affects the report indirectly, the attendance and participation by committee members has been far worse this year. I mean, we had 3 people there today for the entire thing. I don't know. What do we have? 8 members on the committee or something like that? And compared to in the past. And so the information that is held collectively by the board is really limited by the lack of involvement of many people in participation. So that concerns me also. I don't know if it's scheduling problems, bad luck, or what it is, but all throughout this project, we've had attendance problems at meetings and hearings, and that sort of limits the amount of information the whole board has. I don't know if anyone shares my concerns.
Yeah, so Professor Rose, I do share your, I would say, commentaries as well. I think, Anna, you were not assigned to this committee from the beginning, but you were in the past. We were sort of used to your cadence, your way of doing things. For example, when we had a panel hearing, we organized it around one day, and we had all the, at least the commitments by all the committee members to be there. And we were able to bring panelist discussions that lasted, maybe good six hours, for example, or 6 to 8 hours. In this particular case, I think we decided to divide it up into a multiple sessions. So for me, to be honest with you, along the way, I didn't get the emails for the 3rd panelist, but I was able to participate 1st and 2nd and 4th. To be absolutely honest, my memories of the 1st and 2nd panelist are pretty shaky at best. And here I am, I'm fairly diligent about attending all these things. So the process to me left a lot to be desired. I don't think it was the most efficient process. And also, I think the chairperson's effort to be as inclusive as possible, even though we had a quorum, for example, we decide upon something, we would keep on having meetings over and over about people who are not there and seeking their opinion about the topics or dates and things like that, which slowed a lot of things down. So I guess my regret is because of the prolongedness of this whole process, just internal deliberation, internal discussion, setting up these meetings. I think the natural outcome of that is a lot of people sort of lost maybe commitment or interest, or this became a bit of a burden. So maybe I don't know about what to do about this particular project, this particular session, but for the future, I think we want to sort of take some lessons from what we went through.
Were any of you here when we held the live in-person meetings? You were, David?
Yeah, I was there twice. Yeah.
Yeah, I was there too.
I'm new, so not I.
Yeah.
But I mean, COVID brought a halt to that, but that process was, I think, had a big sort of impact on committee, the people getting to know each other and much more live interaction. And it worked rather well. And the attendance at those of people was decent. And with Zoom meetings, it's a lot easier to participate. And so it's even more disappointing that our attendance has been low and maybe people have lost interest. My memory on the earlier is spotty at best. I don't know if I think a number of the presentations people have been reading from papers. And I don't know, it's not uncommon when you have hearings to ask people if they're interested in submitting written comments. If there are any of the speakers we've had who have written papers, it's a lot easier to review those than to listen to a recording. So to sort of get a better understanding of where we stand, it might be useful for Anna to sort of create a summary of what's happened on this report, of who testified, maybe a very brief summary of what they said, and attaching, if possible, any written reports. I'd feel more comfortable rather than just sort of expressing my kind of gut reaction of seeing a written summary of what we've done on this report and the witnesses and what they talked about, and would make it easier for us to make a judgment about what to do next.
I would second that as well.
I don't know how you feel, Christina.
Yeah,
or-
well, you
or
know,
Patty.
well, I'll just say again, I know that I'm sort of the new, I wasn't privy to the way you all did previous meetings. I share your concerns though, just even not having those previous meetings to compare to. And as I mentioned, I do think, I mean, the scope of our project, we narrowed it, but it is broad. We did sort of have testimony from all over the place, and not to reiterate what you all have already said, but it was over long periods of time. And so I do think it would be helpful in whatever form that takes, even if we just go back through. But I do think it would be helpful to kind of do a recap of what we've learned. But I think, like, again, for me, what's missing in my mind without going back and thinking through what each person has testified on is just, I do think there are some areas where we've had some helpful anecdotal presentations, but maybe some of the data is a little bit sparse. And it might even be helpful for us if we go back and revisit some of the information we have gotten, and then follow up. I know we've done some follow up. I know some folks have pointed us to data sources that we may be able to consult, but maybe there's just some ways that we can kind of plug in those holes without bringing, without doing another briefing, but just following up maybe with some panels to get additional information. But I share all those concerns. I do think, again, without having anything to compare it to previously, I do think that we are probably lacking in quite a few ways. But that said, I also do feel that there's nothing we can do, I guess, to go back and make up for the long delay. But we do have a situation now where we probably at some point need to cut our losses and do our best we can to wrap up the information, get a handle on what we do have, what else we need, and then move forward with producing a report.
Also, if you do a summary, maybe we can get, which can end with the kind of questions you have posed now. Where do we stand? What do you think? Do we have enough information? We might be able to get the reactions of more than the 3 or 4 of us. I don't know, Patty, do you have any feelings on this?
Yeah, to be honest with you, I mean, I agree with you and I agree with everyone, but here we are, we need to deal with this. But I think moving forward, I think, going back to a process where we're doing it more near in time, because I don't really remember all of the presentations. I remember some of them. And so that, I think that is the challenge. But I think if we could get a summary and see what we're missing, that would be helpful. Because we're not going to be able to move on to anything else until we're done with this project. And it is an important project. It's just maybe we didn't get all of the witnesses, the data that we need. So is there a way that we can get that in the record so we can review it? Because some of it exists, and can we get it without having to do a whole new briefing?
So let me go ahead and have the last word because I don't want to go beyond 2 p.m. I can certainly provide a summary for each of the testimonies that you received. I can also provide a cleaned up transcript of those web briefings so you can refer back to them. I will try to track down some of the data sources that were cited in each of the testimonies and maybe flag specific pages that you should review. I'll try to do as much summary as I can because it sounds like you'll need to review that information before coming prepared to a debrief meeting. I think I agree, everyone needs to be on the same page so that you can have a fruitful debrief. I'm just looking at the calendar right now. It will take me, I do have a couple of other advisory committees that I'm working with right now. It's possible that I can get this to the committee the middle of April to the end of April. And then at that point, I'll sort of give you kind of a timeline on how long, or I guess a timeline in terms of like when we would have our debrief after that, because you'll need that information in order to have that debrief. So, you'll need some time to digest that information, maybe have some questions, that sort of thing. So I want to make sure that you have enough time after receiving that information to review it. It's likely that we'll have a meeting if we're just at this, based on this kind of timeline that I'm creating right now. We could have a meeting maybe mid-May, toward the end of May. I'm just kind of setting some expectations right now. So I hope that works with you kind of generally right now in terms of next steps. There's only 4 members on right now, so there's not a lot that I could,
Anna,
not any other input that I can receive. What's that?
Would it be possible, maybe while you're working on putting that together, and thank you for doing that, would it be possible for us to do like a scheduling survey to try to, if we want to aim for like a May date for a debriefing?
Yes.
That way we can, because we'll probably have a greater likelihood of having folks being able to join if we can get that on their calendars as soon as possible. And then that way that'll be on the calendar before summer starts. So
absolutely. Yes, we can certainly do that. It's 2:02,
yes.
so I'm sorry for taking more time, but thank you all for your participation. And go ahead, Christina, if you want to make any last announcements.
No, I appreciate everybody's time and bearing with me being your replacement chairperson for the day. So thank you all for joining. We'll go ahead and adjourn. It's officially 2:03 p.m. So thank you all and have a good rest of your day.
Hi, everyone. Thank you.
Bye. Thank you.
Thank you. Bye, everyone.